So now that I have a minute in between surgeries, I wanted to talk about facelifts. And the question that we get this year more than anything, I'm not sure why, is what is a vertical facelift? And this to me is a question that should have been asked 15 years ago when the idea was introduced, but for some reason it's become novel and people think this is a new concept. It's a fairly repeated concept over the past decade, but the reason this is important to think about or know is that in general, just so everyone knows, the types of facelifts that are done now in the year 2021 are mostly relatively vertical. And the reason this matters is because in the past, as patients would come in, surgeons would do what the patient asked pretty much, which was, ooh, I want to have this. And patients kind of pull in this direction, or they grab their neck and they pull in that direction. And the facelift would be done in those directions. That is not proper, since the face actually gravitates and comes down this way, and the neck also gravitates down towards the midline in this direction. So realistically, when you lift somebody, the logical thing to do would be to just lift against where everything fell down. So if it falls this way, you want to go back up that way. And in fact, we have several attachment points on the face that are tethered, and everything around that droops just like that, and then they both kind of fall into the neck. So when you pull a neck, you don't pull it in this direction. Nobody aged in this vector. We all age in this direction. So that's roughly vertical, and this is opposed to lateral facelifts, which were done in the past, that would give somebody what we call a lateral swoop deformity or a lateral sweep, where they get bunching from redundancy around the center of the face, or they get scarring because they were pulled in a vector that they didn't age in, meaning there's tension there because they pulled where there was no excess and they left all the excess behind. Posterior neck lifts have that same issue. They pull too much in that direction. So then a couple doctors came and said, okay, let's go vertical. Then they went purely vertical. They went all the way up, and what happened was they were getting pleats in the neck, again, because they had some lateral excess. The proper direction, as determined over hundreds of surgeons undergoing little bits of evolution and research studies, was found to be roughly around 60 degrees, and that's kind of up in this direction as you're seeing, which also happens to be perpendicular to the nasolabial fold, like this, and in the direction of the zygomaticus major and minor muscles. So the direction that we need to lift in is about 60 degrees. Now, this does not apply to every person. We don't all age in the same exact vector. Some of us fall more anteriorly, some of us fall more inferiorly, which means some of us need to be pulled more laterally, some of us need to be pulled more vertically. We don't need to measure to figure that out. We need to figure out how to do better facelifts and neck lifts. So these numbers were super important in the past when the tethering in the face existed with all these kind of older mass plication type lifts. Now, however, progressing to the deep planes and the more extensive deep planes, we realize that we don't need to measure where the face is going to go. We just have to go release all the tension in the face, give it a little bit of lift, and you see it goes directly to where it wants to go, or where the maximal excess was. So all facelifts should be done in a relatively vertical plane or a relatively vertical vector. That's roughly 60 degrees, which means it could be 40 for some patients, 60, 70 for some patients. On a revision, it might be completely vertical because they were pulled completely lateral. The main concept to understand is the more you release in the face of the connections within these layers of the face, the easier it is to lift someone appropriately without measuring it, overthinking, and trying to figure out where the face needs to go. Instead, you release the tension in the face, and the face tells you where it wants to go. Same thing happens with brow lifts. You release the brow completely from all its attachments and tethering points, and when you lift it on any given patient, they will lift back to where the brow wants to be, which means you never lift them in an unnatural fashion. The other confusing point with vertical or lateral lifts is that patients think, from what they've read online, that all these fake deformities come from the prior lateral lifts. A lot of surgeons believe that too. Realistically, that lateral pull around the mouth and stretching of the mouth and changing the way the face moves also happens with doing mass plication techniques with suture tethering, meaning they grab they lift the skin and the surgeon will go and actually throw a suture into the lateral muscles around the mouth or into the zygomaticus muscles and try to pull them, not having released it from the deeper planes. This can also cause that deformity that we see in the face, regardless of what direction you're pulling things in. You shouldn't be pulling the dynamic muscles. That's the benefit of these deep plane techniques and extended deep plane techniques, is that if you look at the face, it glides down when I move it around. And this happens in all the layers of the face like this. The bottom layers don't move so much, the top layers move more. And it's a relatively greater movement in the superficial planes of the skin than it is on the deep plane where the periosteum is, that hardly will move, obviously, because it's attached down to the bone. The deep plane techniques follow this logic and they go into the separating plane that's called the deep plane or the gliding plane of the face, easily separated because it's a glide plane. Lift everything back up, put it back down. That's called a deep plane. And there's different attachment points that we need to release to get that to move. But once we do, this whole idea of vertical lifting becomes relatively unimportant because we don't need to measure where we're going. We just release and lift. And patients ask that all the time. How do you determine how much you're going to take? How do you determine where you're going to pull it? And the answer to that is I don't do that preoperatively. I get an idea by playing with the face, but all I need to do is release the tension in the face, allow it to go back to where it wants to be, and then just trim the excess. That way everybody gets the biggest lift possible without causing any kind of unnatural pull. So in general, all these newer types of techniques are relatively vertical, not purely vertical. And the real question for patients who are looking for good surgeons is not what technique are they using. We have photos. Go look at the photos. You're going to look at someone's before and after photos, and that's going to tell you what technique or what doctor you need to go after, is not what technique they say they use. I can tell you I use a vertical, a minimally high SMAS, extended high SMAS, lateral SMASectomy. I can use all these words that don't really mean anything unless you're blinded. And then someone says, well, you're going to pick between these 5 different doctors. One of them uses a deep plane, one of them uses a SMAS plication, one of them uses an extended SMAS, high SMAS. What are you going to pick? If you're blinded, then yes, pick the more advanced technique. Otherwise, the technique name doesn't matter. Doctors who use the techniques I don't like can get an incredible result. Doctors who use the technique that I do might not even get close to the result that I get. So realistically, what the patient needs to do is look at the before and after photos, see who gets the best result, and overall, so not just limited to one kind of face or one area in the face, who can really rejuvenate the face best. Then you have to meet that surgeon and then see if you like that surgeon, because that is very, very important. I've been through this many, many times, and not everybody likes me. So if I take on those patients who are struggling because they want my result, they want my technique, but they don't necessarily get along with me, we're going to have a lot of issues, because surgery is a tough thing to go through. It's very, very difficult, and patients will get stressed, and you have to be in the same level the whole time, talking about everything, making sure you do a lot of hand holding and take care of the person as they go through it. If it's somebody who doesn't get along with you well, it's very difficult to do that hand holding. So please understand, it is not just about the result. You do have to meet the surgeon and make sure that you can get through this very rough experience together. So all of this was said to say, don't worry so much about vertical this, horizontal that. Really go look at the results. Aside from that, once you do that, then you can go meet the surgeon or do a virtual meeting with the surgeon and see if you have the same kind of personality and the same, I'd say, ideas of what you want done versus what they want done. So I'll post this later so people can see, and I do have another video kind of showing facelift incisions so you understand why we make them where they are.